Uh, but I'm going to talk a little bit about how we're managing opioid use disorder, dependence, and pain in the hospital at Temple. Um, and so just to maybe to get started here, sorry, I'm situating all my windows here as I share. So just a little background about what I do. I'm an emergency physician by training, and so that's my major job. I'm working in the emergency department at Temple and Episcopal. And if you're not aware of sort of where we are in Philadelphia, we're sort of in North Philadelphia and near the Kensington neighborhood. So we're sort of at the center of the opioid crisis for Philadelphia, where all the overdoses are happening. It seems like, I don't know, maybe it's pushing towards West Philly, as Jean Marie just showed those pictures, or that slide. But then so clearly, like, I'm part of the overdose crisis in the emergency department. But I'm also a medical toxicologist and addiction medicine specialist. So I'm running an inpatient consultative service for addiction medicine, managing people with dependence, withdrawal, overdose. And then I work in an outpatient setting, one in the Trust Clinic, which is our OBOT at Temple, and then a mobile unit, low barrier access, called Begin the Turn. There's lots of different areas that I'm coming from. But to sort of set the stage of this clinical picture, I offer you Matt. So he's a 28-year-old male with a soft tissue infection in his left arm. You know, he's right-handed, so he's injecting mostly in his left arm. And he's been dealing with an infection in his arm for about 3 weeks now, and he's only coming to the emergency department today because he's got fever, chills, and malaise. You know, he feels too sick to even go out and use right now, so he's coming into the emergency department. You know, he's avoiding the hospital for weeks. He's been trying to IND it himself. He's been buying antibiotics on the street to sort of treat this problem. And now he just sort of has given up and is now coming to the hospital. You know, he's been avoiding the hospital because his past experience has been awful. Lots of stigmatized care. People said awful things to him. He's gone through withdrawal. He knows what's happening and he doesn't want to come to the hospital. And so when he gets there, he's sort of like in late stage disease. He's pretty sick. And we offer him 2 milligrams of morphine IV. And clearly he gets no relief from that. And, you know, if you look through his chart, there's lots of visits for overdose, infection, and altered mental status. And every one of them, he's left AMA. And on his problem list, there's all kinds of stigmatizing pejorative terms like IBDA, polysubstance drug abuse, and drug-seeking behavior. So really, it's stacked up against him, but just even before he hits the door. And so he gets admitted for this infection, and the doctor who's admitting him puts in the analgesia order set of 5 and 10 of oxycodone, Q4. And I don't see too many faces, but I should see a whole lot of eye rolls. Maybe there's an eye roll emoji everybody can put up for 5 and 10 of oxycodone for someone with, who's using a bundle of heroin a day. But throughout the night, you can see he's getting increasingly agitated and he's asking more for pain medication. He's saying, like, if you don't give me these, I'm going to leave. And really, it's perceived as like he's seeking drugs, like looking to get high from the opioids that we're going to give him. But you'll see from this talk that it's quite the opposite. He's like looking to stay. And he knows you're going to do everything to help him, but that's not how it's read. And, you know, really, we should be changing the paradigm for this because people see Matt. I mean, Matt is a patient that I see, 10 times a week. You know, there's like a couple a day that come into our hospital that have Matt's same exact story. And everybody looks at Matt like, you know, what's wrong with this person? What's wrong with Matt? Like, why did he pick this path? Why is he coming here? Why is he doing this? And why doesn't he just stop his behavior? But when we really look at it, that this is a chronic medical disease, and there's a lot that went into how Matt got here, and it's not a choice. We should really be changing the paradigm to thinking about, like, what happened to Matt? What happened to him that brought him to develop this disorder? And we need to be trauma informed when we take care of Matt, because when you talk to Matt and you find out his story, you find out he's had some really bad events happen in his childhood, and he's had some genetic things that have led him to this disorder. That, you know, lots of his family has also dealt with substance use. You know, Matt felt like he grew up like any other kid in his neighborhood, but it all changed when he took a Percocet in his sophomore year of high school. and it led him down this path that none of his friends did. And they were all doing the same thing, but things were stacked up against Matt. And so we really need to be talking about this as a chronic medical disease because the outcomes are all the same. And when you track it back, actually, we hold substance use disorder to a higher standard than we do for hypertension, diabetes, asthma, CHF, and they all have the same sort of pathways to get there. So, partly genetic, a lot of environmental and behavioral things go into this. And the problem is that people with low socioeconomic status, lack of family support, and psychiatric comorbidities have worse outcomes. And I've just described what most people who are dealing with substance use disorder are struggling with too. And so the outcomes really are bad sometimes. And it's unfortunate because people with substance use disorder routinely receive substandard care. It's all too often that I've heard people talking about patients with substance use disorder as a burden on the system. We create these barriers that are so high to get care that people just give up. They avoid medical care because of stigmatized care in the past, and then they come to care at a later stage of disease and have worse outcomes. They really have decreased their access to treatment. And this is a slide that I've just thought about so often that boy, if we gave the same type of care that we do for patients with substance use disorder as we do with other diseases, this is what it would look like. I'm sorry, I can't treat you for your diabetes until you've decided to not eat sugary foods, or this is the third time you've had a heart attack. We have a 3 strikes and you're out rule at our program. Or, hey, why are you in DKA again, even though I didn't give you insulin to keep you out of DKA? Or we're going to hold off on treating your cancer until you get your diabetes under control. These are all things that we're doing for people with substance use disorder. It really needs to change. All right, so on to heroin, and I'm going to keep a lot of this stuff short, this beginning stuff, because you guys are all experts in this already. And I know you've had talks about this in the past, but the top left is black tar heroin, needs to be cooked, hard to solubilize. We don't really have it much in Philadelphia. This is more Appalachian, West Coast state. What we really have here is the white powder heroin that's in the top right corner. That can be snorted. It can be injected. It's very easily solubilized with just a drop of water. This is the needle that people are typically using to inject this. That's a BD needle, an insulin syringe that's just a cc. So about like 0.4 people are drawing up to inject. It doesn't take much to solubilize white powder heroin in Philadelphia, and we have very potent heroin in our neighborhood. They come in these glassine paper containers, these little bags, and sometimes sold as loosies or as in a bundle, which is typically 14 bags in our neighborhood. And it's not just from the bags of heroin that people are getting opioids. Lots of the counterfeit medications in our neighborhood contain fentanyl. And this is really a fentanyl an epidemic we're experiencing here. But if someone goes to buy Percocet on the street, a Perc 30, it rarely is oxycodone anymore. It's typically a pressed fentanyl tab, and it's the same thing with our street Xanax and this health advisory. I know that came out of a lot of work that Jean Marie and you guys at Penn did about cocaine, fentanyl contaminated cocaine. And then we're seeing it contaminated with K2 and K2 in our heroin supply and xylazine in our heroin supply, which I've been talking a lot about recently. There's, it's sort of all these drugs are all intermixing. But this is a question I get often, like, well, how much is in a bag of heroin in Philadelphia? And I think you really can't take this information outside of Philadelphia. If you're working in Camden or you work in Chester or you work in Baltimore, I think this is all very different. Or maybe even it's different in South Philly and West Philly than it is from North Philadelphia. And I think this changes from week to week too. But I think a bag of heroin fentanyl mix is approximately 30 to 70 milligrams of IV morphine. So someone who is opioid naive, really, this is too much opioid for them, and this is why we see overdose deaths with just a single bag of heroin. And if we're thinking that somebody who's using a bundle of heroin a day is injecting, somewhere between 420 to 980 milligrams of morphine daily, this is enormous doses. orders of magnitude higher than what we're ever giving in the hospital. And I think that somebody who's using 2 bags to get well in the morning, they're injecting somewhere between 60 and 140 milligrams IV. When I teach this, I think I talk to residents and go, like, what's the highest dose you've ever ordered? And certainly not 60, maybe 8 as the most. And someone is, just to get well, just to feel normal, is injecting probably 60 milligrams of morphine or higher. And so we compare to what people are experiencing in the hospital. Here's a bundle of heroin a day. We're almost getting up to 3,000 MME. Fentanyl 200 micrograms per hour is in the 1,400 range. So like for patients who are in the ICU getting continuous infusion, or someone who's started on 100 milligrams of OxyContin 3 times a day, that's under 500. But yet we look at the people who are getting 100 of OxyContin 3 times a day, and you're saying, oh my God, they're getting these huge doses. But geez, look at that compared to what a bundle of heroin is today on the street. So it's really hard to get the dose right when we're taking care of these patients. And so just review what tolerance and dependence is. The tolerance is you need more of the drug to get the same effect. And so as that happens, you also become tolerant to respiratory depression effect of opioids. And if you see here at this point here, if everybody can see my cursor, you're barely getting above the euphoria line, but if you track it back to when they were opioid naive, that's a dose that would have killed them. But then all the while, as you continue to use, this withdrawal line appears, and that denotes dependence. And so we see here in these late stages on the right side, people sometimes say, I'm just maintaining, I'm just using just to stay out of withdrawal. I use 3 times a day or 4 times a day, and I use just to stave off withdrawal. And so opioid withdrawal syndrome is what we're really managing in the hospital a lot. And everyone knows what opioid withdrawal looks like. It only takes a couple hours when you're using fentanyl to start symptoms of withdrawal. And we use the CAUS scale in our hospital to, make the most objective assessment for patients who are going through withdrawal. But you can see here that a lot of these things are not objective; they're subjective. So I walk into the room and I get a CALS of 14. The next person who walks in, maybe they ask the same questions and the answers just come out differently, or maybe they're perceived in a different manner and they get a 16 or a 10. Because a lot of these things are, like I said, subjective. I can't see necessarily that someone has myalgias. I can't see that they have stomach cramps. I can't see that they're anxious. When it's really severe, you walk into the room and you can see that person they're in withdrawal, they're dripping sweat, they're yawning, they've got piloerection, maybe they vomited or they've got diarrhea. But for the lower areas which are concerning, someone may just have the sheet over their head and the provider looks at them and says, oh, they're comfortable, they're not in withdrawal. But you actually have to ask those questions to really determine if they're in withdrawal. But I think a lot of the people who are in the mild to moderate range are getting overlooked that they've got opioid withdrawal. And this is what leads us to a lot of our AMA dispositions. This was something that we looked back in 2016. It was hard for us to determine how many people in the hospital actually had opioid use disorder. So we looked at the diagnoses in particular, and we looked at infective endocarditis because we knew that almost all of those patients were people who were injecting drugs in our hospital. And our AMA rate was 12. And I imagine it was probably around 20 or 30% because then when we got a little bit, and so this is what we were doing at the time. If we are offering people opioid withdrawal management, we offer them the 30-20-10 taper. And again, I should see lots of eye rolls because I think everyone's experience with the 30-20-10 taper is that it's just really not effective. Because this is what it looks like. Maybe on day 1, 30 gets them out of withdrawal, but on day 2, when they realize they're getting 20 oh wait, it's not going to be any better than yesterday. That's the best I got. People are getting up and leaving within 24 hours. Because, 30-20-10 taper doesn't mean on day 4 that you're cured of your disease and that you no longer have dependence. This takes weeks to overcome. And so this is just not a good way to manage patients. And so this is why we saw so many AMA discharges from the hospital, because this is all we really had to offer. So when we started an addiction medicine consult service, we were able to decrease our AMA rate from 37.5% down to 13.8%. So it made a huge impact in our hospital. And this is only sort of in the very beginning when it was one provider who was trying to run around like a chicken with his head cut off, trying to do all the consults. And we were able to do, a pretty good job. And things have gotten better since then because now we have lots more providers and we've got lots more education and everybody's sort of on board with managing this, but really doing it in a phased approach, giving all of the drugs you can to keep the person out of withdrawal to stay for their care is our number one goal. And so this is what it looks graphically, when someone's when we're trying to treat withdrawal. So this is someone who's opioid naive and they start using heroin and it tips the scale to euphoria. But as they continue to use, they develop this dependence. And so now that person could have just used, 100 of OxyContin, or maybe they injected a bag of heroin and they're walking down the street and they look like everybody else. They don't have no signs of sedation. They don't have an opioid toxidrome. They are just meeting their dependence. And the problem comes is when we remove those opioids, whether they get, imprisoned, get forced detox, or they get admitted to the hospital, or they go to a detox center, the dependence tips the scales and now they're in withdrawal. And so what do you have to do to make that person feel better? I mean, it's really obvious. You just have to match that dependence. And it doesn't matter what you use, whether it's oxycodone or methadone or buprenorphine, you just have to meet that dependence. You have to fill that receptor at the same level their dependence requires. But it's easier said than done, right? Because how do you figure out what that person's dependence is if you don't know what's even in a bag of heroin? They give you some information and maybe you have to ferret that information out to sort of infer, but even at best, you're guessing. And so some things that we like to ask, and not necessarily the total dose of what you use in a day, because I think that's what most people say, like, how many bags of heroin do you use a day? And the reality is, if you are living on the streets and you're living from bag to bag, you oftentimes aren't keeping count of how much you use. I mean, as much as you can get in a day is usually the answer that I get. But so there's typically a range. And I think probably a better question is, how many bags does it take you to get well? But unfortunately, it varies from day to day, and people will say, "Oh, if it's a good bag, it's only one, but if it's not, three." So this information is really difficult to get, and so it's really hard to pick that dose of opioid that's going to meet that dependence. But what I can show you is that we almost never reach that dose because those doses are so high. And then if you actually want to get some pain control, you've got to tip the scale a little bit more too. More than their dependence is, so then you can get some pain relief. And so a good example is someone who the dose, like they're on methadone. They're going to a methadone clinic and they're getting 100 milligrams a day, and they very regularly go there, but they come to the hospital for like a traumatic injury, like they break a hip or something. And in room one, that person is getting methadone 100 milligrams a day. We're giving them 100 milligrams a day and they're screaming in pain. They're uncomfortable. And then the next room over, they may be the same injury and we're giving them 10 milligrams of oxycodone every 4 hours and they're completely comfortable. And the doc goes, "Well, this isn't making sense. I'm giving 100 milligrams of methadone to this person and 10 milligrams to that person. Like, why is that person still in pain?" And it's because you essentially have given them no opioid. You have just met their dependence. And so what you need to do is give a little extra, and it can't be just a regular dose. You can't give 10 milligrams of oxycodone. You actually have to give a tolerant dose to tip that scale. But the reality is this is what we're doing for so many patients. We're giving just these teeny tiny doses, and they're never getting any pain control, and they're just in withdrawal. And so the mantra that I try to use is overflow the bucket, because pain is a mix of both dependence and analgesia. Pain controls both dependence and analgesia. And so if you give a dose of an opioid, it goes directly to your dependence bucket and you get nothing out of to your analgesia bucket. And it's only when you overflow the dependence bucket do you get some analgesia. And so we need to overflow the bucket. And this is why we do some long-acting opioids and short-acting opioid combination. So the long-acting goes to keeping that bucket full. So every time I give a short-acting opioid, it overflows that dependence and lands in the analgesia bucket, and people get some pain control out of this. And I try to make this as much analogous to other medical diseases as possible. And what else does this sound like? with long-acting and short-acting. Sounds like diabetes treatment, right? It sounds like giving Lantus and you're short-acting. We're giving a basal dose insulin and we're giving short-acting for every meal. And so that should be like a 50-50 or 75-25 combination. It shouldn't all be short-acting and it shouldn't all be long-acting. It should be a combination of the two. And that's sort of what we're doing with pain control. And because this is what it looks like when you're just doing short-acting, you give this big dose of opioid and maybe they feel better for 5-10 minutes, but then they spend 2 hours waiting for their next dose and withdrawal and they feel sick. And then they feel better for 5-10 minutes and then it goes away. And when you ask the patient, how's that working for you? They're saying, oh, I feel terrible. No, it's not working at all. This 2 milligrams of Dilaudid you gave me is terrible. It doesn't work. And so then what does the doc have to do? And they just increase the dose, right? Or maybe increase the frequency, but boy, you can't increase that frequency enough to meet that demand. And so really what we need to do is be adding long acting so you're never dipping below that withdrawal line and you're adding short acting on top of it. And the mantra that I like to talk about is the house that OxyContin built. Like OxyContin is the foundation of your treatment, and then you're adding short acting on top of it. And without that foundation, everything falls apart. And if you're saying you're not getting enough pain control, there needs to be raising that foundation so the short acting can work. So it really is based upon the long acting medication. So remember, detox is not therapy. Detox alone is not therapy. It actually puts people at high risk for overdose death because people returning to unstable environments with no tolerance have a real high risk of overdose death. So we actually need to keep people's tolerance up. That's a protective mechanism for them. So even if they're telling you, Doc, I'm going back to using soon as I leave the hospital, well, we need to keep their tolerance up. That's actually an even more important scenario. Because we can see here from this JAMA article about people leaving Ontario prisons that just high risk of overdose death in those first 5 days if they're in forced detox when they leave. All right, so back to Matt. Matt leaves AMA later that night only to return 2 weeks later in septic shock. He's now in the CICU. He's in heart failure and he's getting a valve repair. And so I know maybe a few people on this call are involved with our overdose review in the city, but we should be doing this in our hospital. Every time we have somebody who's getting a valve repair for endocarditis, we need to do a biopsy of how many times that person has come to our hospital, how many missed opportunities were there, and now we're doing multi-million-dollar operation for this person because we failed to get their medical disease under control for those first 5 times they came to the hospital. And when Matt was crying, for help, he was threatening an AMA, we really should be looking at that as, he's looking to stay in the hospital. He's trying to stay to get his therapy because he knows he's going to be sick. Most providers are looking at it as like this guy is seeking drugs, trying to get high. But reality, what he's saying is, I want to stay for help and you haven't given me enough medication. I'm going to have to leave. I'm going to be forced to leave to go use to get well again. And unfortunately, too many times we're like sort of teed up for a failed system here. Too many docs have to walk in the door and the AMA paper is already signed and this has been building over the last 6 hours and they're sort of forced to do the Matador approach. But they just let that person go because they have no ability to recover care. And so we need to be thinking about this as a dopamine deficiency problem, just like diabetes would be an insulin deficiency. We need to get that person's dopamine level back up to where they no longer are triggering their fight or flight survival mode mechanisms. So our goals for inpatient opioid withdrawal management should be really in 3 phases. And the first phase is really the most important phase to all of this. That's the most complicated. It's getting someone's opioid withdrawal symptoms under control. And so if that person requires emergent medical treatment or requires inpatient treatment, they've got a bloodstreaming infection, they've got endocarditis, they've got epidural abscess, we need to be doing all we can to keep that person's symptoms under control so we can maximize and complete their medical and surgical therapy. So we're looking at reducing AMA discharges in that phase. And then once that phase is over, moving on to phase 2 where we're starting and stabilizing them on medications for opioid use disorder, whether it's methadone or it's buprenorphine. And then the phase three is that transition to care phase, which is so super important too, because we lose so many patients in the shuffle as they're leaving the hospital. But when we're talking about treatment of opioid withdrawal, there are lots of medications that are available, but really the main part is the opioid replacement. There's so many other medications that go into this that, sometimes people will term comfort meds, but really the major portion of this is opioids. And so we're talking about oxycodone, extended release, methadone, and buprenorphine. Those are the three major ones that we're using. There are other medications that go into it, like I said, NSAIDs, acetaminophen, gabapentin, benzodiazepines. And I'm not really going to talk so much about xylazine today, but people are also experiencing withdrawal from their xylazine or maybe even benzo withdrawal. And benzos as an adjunctive medication is very important. And then when it comes to pain control, sometimes you just can't get enough opioid in that person to get them comfortable, get their pain relieved. And so moving on to more advanced treatments like ketamine infusions can be really helpful. Then, they're not really mu receptor dependent. And regional anesthesia. And boy, I wish I could offer this to all of my patients, especially the ones with forearm infections or leg wounds and leg infections. If I could do a regional anesthesia for an extended period of time, I could really decrease the amount of pain that they have and the opioid required to treat that disorder. And so we're trying to start an ultrasound-guided regional anesthesia program where we're going to be doing injections for those patients on a daily basis to try to get them through that. Because, anesthesia is not necessarily, involved in some of these cases. Our pain management team is really treating intraoperative or postoperative pain, and they don't have time to be able to do it for all these patients. But I really think it's an important population that we should be utilizing regional anesthesia. So what are the barriers to administering the effective doses? Because like I say, that's my biggest concern. I can't get enough medication in patients to get them comfortable. The dose can't get high enough. And I think the biggest barrier that I face is the stigma. I mean, it starts at the doorway. First a patient arrives and the security guard or the person who's checking him in, and stigma starts at the door. But when they actually get admitted to the hospital, and we're talking about providers, I hear all kinds of things said to patients like, why don't we search all our drug addicts before they get admitted for drugs so we can stop them from using or getting high in the hospital? And it just screams to me that this is like a stigmatized situation. And we really need to change that and turn it around and build a therapeutic relationship with patients. Unfortunately, I know a lot of staff has some really bad past experiences, whether it's personal from family or maybe it's treating other patients who have had use disorders. There's a lot of trauma that's involved in caring people with substance use disorder, and we got to be cognizant of that. So not just the patients, but also the providers. What provider has a sibling that is struggling with a use disorder? Who lost a parent to an overdose? Who has been through a lot of this stuff in their life and is bringing their personal experiences into the care of the patient. So you got to be cognizant of that. And we really need to be utilizing peer recovery specialists and patient advocates in these scenarios. I would love for a patient advocate to be with every single patient who comes to the hospital with an opioid use disorder. I think it really reduces the amount of stigmatized care we give people when there's a third party involved in this. Really levels the playing field. And having the credible messenger at the bedside who can relate the message that the doctor is saying to the patient, or maybe the other way around, the patient's story being told to the provider, so we can all talk in the same language and level the playing field. I think it's really helpful. Education is a huge part of this. I'm oftentimes going around and teaching people about dosing and tolerance and dependence, and sort of equating that. Yeah, I know I'm giving this person 200 of OxyContin, but I guarantee you that that's an order of magnitude too low to treat their dependence. And this is a safe scenario, because I get a lot of this, I don't feel comfortable doing this, from providers. And it's really, the safety concern is just a lack of understanding of the dosing that people are using on the street. And it's unfathomable to some providers when you educate them about what's in a bag of heroin fentanyl in Philadelphia. And then they understand, once they realize that, oh boy, they're using 3,000 MME per day. Oh, okay, yeah, this is going to be safe scenario. But then even when everybody is on the same page about the safety concerns, now we run into problems with restrictions and guidelines on the floor. And it's probably different at every hospital. And I imagine there's some people from other hospitals on the line here. But at Temple, we have, max dose. And, you can't give more than 2 milligrams of dilaudid or hydromorphone IV at a time on the floor. And so we bump up against that problem. It needs a provider, and a doctor needs to be there to administer it if it's above that dose. Or maybe there's a dosing interval problem. You can't give it more than every 3 hours. Or you can't give benzos and opioids to the same patient at the same time. Or, this floor doesn't take PCA pumps. We don't have the monitoring available for that. And so there's lots of these guidelines and restrictions that go in that make it difficult to manage opioid use disorder on floors. One thing that you can do in your hospital, I think, is put it out all on paper. Create an opioid pathway, and that's what we've done at Temple, or in the process of doing and improving it. And I hear oftentimes, oh no, sorry doc, we can't do that on this floor. That's above our guidelines. Well then, fix the guidelines and get rid of the things that are preventing care, or create a caveat for people who we've identified to have opioid dependence and tolerance. And so using medication pathways is really important. So we've got this medication pathway in place here where we're using OxyContin starting doses of 60 plus PRN doses. And if that doesn't work, we're using a PCA pump to deliver care. But this is what it looks like for patients who have opioid tolerance and dependence. We've identified that they're not going to do well with just regular doses of opioids. We're going to start with 60 milligrams of oxycodone extended release every 8 hours, and we're going to titrate by 20 every 8 hours until they're comfortable. And that's actually really on the low side. This is a super conservative approach, and I think over time this is going to just increase as doctors become more comfortable with managing this. But this is your blanket dose for someone who is, not even taking a good history about what they're using. We just identified that they have tolerance and dependence. This is their starting dose. Because there's people who come in that I know I know what their dependence is, and we're starting them at 150, 200, because we know that they use 3 bundles a day. And then when you're adding PRN opioids for pain control, we got to make sure we're using tolerant doses. So not 5 and 10, but we're using 15 and 30, or maybe even 45 for moderate pain, and then 2 milligrams of hydromorphone IV. And it really is, I'm using the max dose I can on that floor until I can change the regulations. So we're using the oxycodone extended release, the long acting, to meet the person's dependence, and then the PRN doses to meet their analgesia. And we're really going to concentrate on titrating the long acting opioids. The house that OxyContin built. We're really going to build up that foundation so when I give that short acting, it's going to work. And that ratio should never be lopsided to more short acting than long acting. And the problem is, though, patients don't necessarily perceive that the OxyContin, the long acting opioids, are doing anything for them, because that time to peak is really long. And so they feel like the OxyContin's not working, but you have to explain to them that, like, without it, the hydromorphone won't be working. And so I'm going to keep increasing that OxyContin dose until your hydromorphone is going to work. And for people that I know that can't take oral medication, and maybe they're NPO, or maybe that the OxyContin pathway is not working for them, we move on to a PCA pump. And so that continuous infusion of hydromorphone is going to take place of the long-acting oxycodone. And that's going to fill up the bucket, the dependence portion of it, and every time they press the button, it's going to give them that short-acting dose, or it's going to give them analgesia. And we're going to titrate the continuous infusion until they can get their pain under control. And our starting dose is of hydromorphone continuous infusions 1 milligram per hour, and that's actually the equivalent of giving about 100 of OxyContin 3 times a day. So it's a little higher than our starting dose by our OxyContin pathway. And there's lots of benefits to using PCA pumps, and I think we're using a lot more of it now at Temple, and I think we're still underutilizing it. It creates patient autonomy. The patient gets to decide when they get more medication. or at least a relative effect. And it's on-demand therapy, like, oh God, I need something right now, and I press that button. And it actually improves the nursing therapeutic relationship. If that nurse is spending all of their time going in giving an opioid, sometimes you see that they almost avoid going in there because they know that patient, every time I walk in there, is going to ask for more opioid. So it actually allows them to do other care now. They're able to do better wound care. They're able to better manage other medications. And it's not taken away from the other patients too, that if they're really hyper concentrated on this patient because they've got to constantly go in to give an opioid, their other patients are suffering. So really putting the care in the patient's hands, creating that autonomy, I think is really important and really beneficial. Methadone, we don't use too much of methadone in our hospital, mostly because we don't have a good pathway for transition of care when they leave the hospital. We don't have a methadone clinic on campus, and boy, it would be really helpful to have that, and you could make that transition. But really, 30 milligrams per day is your top dose in the beginning, and that doesn't amount to a lot of opioid. And the problem is, if they aren't already initiated with a methadone clinic, when we send them to a skilled nursing facility, it's going to be really difficult to get them methadone while they're there. We really have to rely on other medications. So when we're starting methadone, we're checking a QTC. We're not trying to go too high in the beginning because you're going to precipitate torsades. But then if that 30 milligrams isn't enough, because that's kind of like, 60 milligrams of OxyContin TID, we're adding more OxyContin on top of that to meet that demand. But there's lots of other alternative approaches that I've seen. So like a 30 milligrams daily with a 10 as a PRN dose, or maybe 10 milligrams 4 times a day PRN. I know some people have used IM methadone. We're not really using it at our institution, but I know other people have experience in using IM methadone. But what I want to point out is it's very clear that the 30-20-10 taper is not an effective management strategy. Day 2, day 3, and especially day 4, that person is going to be feeling sick. And like I said, a lot of the problems come with transitions of care with methadone. It makes it very difficult. And so how do you transition that patient to a methadone clinic if you've titrated them up to 100 and they have to restart at 30 at the methadone clinic? You really need to have good communication with that methadone director. But buprenorphine is a great option. I'm not going to go into the pharmacology of this because I know you guys know all this information, and it can be prescribed in an outpatient office, and it's got a ceiling effect. And if you give it too early, people get precipitated withdrawal. Not a lot of patients are willing to start with buprenorphine in the beginning. They are very worried about the withdrawal, and it's not an option for them if they're staying in the hospital. We've got a pathway on board, so if anybody is confused about how to use it, we've got something that they can look up. And it's your sort of standard approach, like your COWS is high, it's been a certain number of hours since your last use, and you start with a small dose. And this is how I teach it. This is how I teach my patients, how I teach residents, how I teach anybody who's starting buprenorphine. I draw it out for them. It's got to be 8 hours from their last use, and once they're past that 8-hour minimum, once they start getting sick, then you need to start with 4 milligrams, and you can repeat every hour until you're feeling well. And if you use too much or use it too soon, you get sick, and if you use too much at first, you get sick. And so we have this 4 milligram Q2 PRN withdrawal pathway ordered for use in our hospital. And then we try to extrapolate what we're going to use after that. So 8 milligrams, either BID or TID, added benzodiazepines for anxiety. But really, I'm sure everybody's having the same experience that, man, 4 milligrams is too much for people in the beginning sometimes. And we even got to reduce it down to 2 milligrams. Or maybe microdosing is the most effective strategy, and we're really working on that as a new option for our patients. But I think learning from some other doctors, actually a lecture that was right in this forum, Dr. Nelson, talking about how fentanyl really sticks around because it's lipophilic. Using the oxycodone for a couple days and washing out that fentanyl may be a really beneficial process. So they remove themselves from fentanyl exposure, they go to another opioid and allow that fentanyl dose to come down, and that's when we start our induction with buprenorphine. But this is what it looks like in the hospital. We'll start OxyContin on patients, and they're getting, 3 times a day OxyContin, and in between they're getting short-acting opioids intermittently. And when we want to transition them to buprenorphine, we hold that nighttime dose. They get short-acting up until bedtime. They get a sleep aid, and then in the morning, when they start getting sick, we start them on buprenorphine as a PRN order. So you can't get it before 8 hours, and then tell the patient when you're sick, you got to ask for it. And so what we're doing is, mimicking what people are doing at home. If they're using before they go to bed and then waking up and using a get well dose, we're just replacing their get well with buprenorphine. And then once they are on buprenorphine, we can add short-acting opioids on top of it if they're still having pain control. Maybe they are requiring a dressing change or something that's very painful. You can add short-acting opioids on top of the buprenorphine. Microdosing options are very interesting to me, and I think there are a lot out there, and I'm starting to accumulate all of them. And we're going to be, testing them out in our institution too, as likewise I know other institutions are doing this. But this is what we've come upon, is using Belbuca. So that's really small doses, 150 micrograms 3 times a day, and we're going to give it at the same time as we're giving the oxycodone extended release. And as we're building up the dose, we are then going to remove that full agonist opioid and just continue on with the short acting. And I expect this is going to be a much better pathway to manage patients. I think probably everyone has tried to do this as an outpatient using microdose induction, and has drawn out this how to split down an 8 milligram film. I tried it multiple times, and I think it can be beneficial for people who are very goal oriented or have the ability to do this, but it's been a failure and a mess for most patients, and come back and doc, that was too confusing. It's really hard to do. But we need to create some sort of process for patients, whether it's cutting down 2 milligram films or, maybe a to-go package with it already broken down for people. I think there's lots of creative things that people could come up with. Dr. Perrone just mentioned the other day to me, swallowing tablets, because you're not getting a full dose when you swallow. I think these are all really good ideas, but we need to create some sort of better plan for people to get induced with buprenorphine, and maybe it's going to be injectables. Some other recs that I give: 4 milligrams 4 times a day is better than 16 daily or 8 milligrams BID. And if patients are not going to be on buprenorphine because they have too much pain, well, then our starting dose is going to at least be 60 milligrams TID of OxyContin. And once they're on buprenorphine maintenance, adding tolerant dose short-acting opioids is absolutely an option. And if they're going to the OR, making sure you have a shared care plan with that patient. Do we need to continue your buprenorphine maintenance if you came in on it? We need to maximize it. Or do I need to hold it because it's a significant surgery like a median sternotomy? You're withholding buprenorphine, starting long-acting, adding short-acting on top of that. ICU setting is a complicated scenario. I know in our institution, 200 micrograms continuous infusion is the typical max on the infusion. You have to go outside the guardrails to administer enough medication. But what I see a lot is people go to get extubated, and the ICU doc wants to take off all of the medication before they get extubated. What I like to do is add on a 1 milligram of hydromorphone per hour continuous infusion, so people sort of level the playing field there. Now you've managed their dependence, and you can go to, that person's not going to be in withdrawal as they get extubated, because we see lot more benzos being used, and it leads to a lot more delirium and more complicated ICU stays. All right, so last few slides here, because I want to leave some time for some questions. The transition of care is really super important. Institutions need specialized SUD coordinators. Someone who knows the system, someone who knows the local recovery houses, someone who knows the back phone line for the methadone clinic to get somebody in, somebody who knows somebody at an inpatient facility. They know who to talk to get the job done. Because when someone's reinventing the wheel every time to get somebody into care like this, it's just too cumbersome, and it never happens. People need to get creative with how we're giving long-term antibiotics because currently we're sending all of these patients to skilled nursing facilities because home infusions won't occur for people with substance use disorder. And we need to work with our skilled nursing facilities in our community so they have the education, the ability to manage people with substance use disorder. Our addiction medicine consults need to be, extending out into the community to do this. And we need to work to get better detox and inpatient rehabilitation care because currently our options are just so limited and patients don't want to go to inpatient rehab because they've had such bad experiences in the past. We need to create good warm handoff. Too often we're sending people off campus for their substance use disorder outpatient care, and that tells patients like, you don't take your kind here. You need to go somewhere else to get your care for opioid use disorder. We need to make it on campus, and we need to make it, a rigorous academic thing, so we're getting people better care, and utilizing recovery houses for people who are experiencing homelessness. I wish I had the ability to improve the level of care happening at sober living and recovery houses. And it'd be great if you had like a Temple certified recovery house or a Penn certified sober living. It would just be, great to do that. So I'm going to open this up to, the group, and I have some other discussion points that I imagine other people are going to bring up too. How about Dr. Perot, and you moderate some questions for these last 10 minutes, and we can go through some of these issues.
Yeah, that sounds great. Thank you so much, Joe.
Mm-hmm.
So I think there's probably a recurring theme, concern about the high doses, getting, buy-in on the floors and nursing to manage the high doses, which I think you sort of touched on. I think Maggie asked, this is really helpful. How do we decide when to use OxyContin versus methadone? Which I think I have that question plus, IV versus PO. I mean, I think a PCA offers a lot in terms of patient autonomy, but not, you don't, PCAs are hard to institute, I think, and time consuming initially on the front end. So when do you go from oral to IV or oxy to methadone or methadone to oxy?
Well, I almost never start with methadone unless it is like a take it or leave it scenario. Like, yeah, I'm not going to stay unless you give me methadone. Because honestly, my management with methadone is really limited in
Mm-hmm.
lots of different aspects. The dose you can give them in that first 24 hours is just not high enough for most people. Maybe 30 milligrams of methadone worked in the 80s, in the 90s when we didn't have these super potent
Mm-hmm.
opioids, but today it's just not enough. So
Mm-hmm.
I'm worried about torsades, but then I'm also really worried about the back end. Like, where's that patient going to go if I get them comfortable on methadone? When I send them to a skilled nursing facility for their long-term antibiotics, they're not going to be able to get it there. So I
Mm-hmm.
really concentrate on OxyContin unless I know that that person is going home and I have a good ability to get them linked with a methadone clinic because we don't have that at our institution. We don't have a good pathway to get people to a methadone clinic.
Yeah.
And then as far as the PCA pump, um,
Yeah.
if I am if I am like seeing that that person is really uncomfortable and it's 24 hours in, or maybe they're asking for a lot of PRNs, or I see a lot of frustration between the nurse and the patient, a non-therapeutic relationship, that's when I move over to PCA pump. Or maybe that person has had failed therapy in the past and they left 24 hours ago and now they're back again. I'm just starting a PCA pump from the door.
Oh, that's great. There's two questions. How are you managing xylazine withdrawal? And I'll actually add to that, how are you diagnosing xylazine withdrawal? When do you get concerned about it? And then how are you managing it?
I'm walking into every scenario assuming that if you're using fentanyl, that you're also using xylazine, and so I'm trying to address it initially. Ask like, do you think that there's xylazine, there's horse tranquilizer in your heroin supply? And I imagine it's almost everybody. So what I'm looking for is people who have lack of other objective findings of opioid withdrawal, like, they're not sweaty anymore, they're not vomiting, they're not having GI symptoms, but they just have lots of anxiety and restlessness. So I think that's the majority of the withdrawal is anxiety and restlessness. And then so uh, it's been very difficult to manage it, honestly. I don't think there's a one answer to do this, but I think making sure you're having gabapentin on board and then adding benzodiazepines. I think for people, a lot of people are saying to use clonidine, but I think I think we're a little off with the dosing there. What's the dose that makes you sedate with clonidine? Well, that dose is going to make you bradycardic and hypotensive too. So I think we're really an order of magnitude off with clonidine. I think these doses that you're getting with xylazine are so high that just clonidine is just a teeny tiny dose and it's just not really effective. So I think we really need to move towards benzodiazepines.
Yeah, I saw a patient last night who had a wide pulse pressure, like 128 over 48. And I clicked on his triage note, and he had a long history of OUD and was probably there for an infection. But do you see specific vital sign abnormalities with xylazine? Do you see more bradycardia? Do you see more hypotension?
No, and xylazine I don't think causes bradycardia and hypotension. I think if it did, we would see almost everybody who is coming in with an overdose bradycardic and hypotensive, and that's just really not the case because from the information I'm getting from the DEA, that's nearly 90% of the heroin supply has xylazine in it at this point in time. And then when you look at the science of it, it's not a imidazoline receptor drug. It's really just an alpha 2 agonist, and so it's not called the imidazoline receptor is really what causes the bradycardia and hypotension with clonidine, oxymetazoline, and these other alpha 2 agonists. So I don't think doesn't cause bradycardia and hypotension. In the off chance that you see a patient who's bradycardic and hypotensive, I think the first thing you should really think of is that they took a clonidine or something like that, because there's lots of that's sort of like involved in a lot of addiction care. But I don't think xylazine is causing bradycardia and hypotension.
Yeah, that's great.
I can
So Ronnie,
answer this question here that Tanya said. How am I setting the PCA pump? I think there's two
oh,
different ways that I use it. If someone's already, if their symptoms of withdrawal are well controlled with OxyContin, I just leave the OxyContin as, and then I use the PCA pump for PRN dosing. And so that allows for more frequent lower doses and gives the patient autonomy so the nurse doesn't have to come in every hour or two to give a dose. They can use that PCA pump to help them with their pain control. Or if I have never gotten their symptoms under control, I use a continuous infusion instead of the OxyContin, and I build up that continuous infusion to meet their dependence, and then use the pump to provide PRN analgesia support. So a milligram per hour is my starting infusion, continuous infusion, and then I start with zero point 0.5 to 10-minute boluses. So that's a lot of opioid, and for some reason the regulation on the floors in my hospital allows that, which is great. And so I'm able to give a lot more opioid on a floor bed.
and are they on pulse oximetry? Because that's
Yes.
one of the, yeah, okay. But not end tidal.
No.
Mhm. And Alex Benil, after stabilizing someone on oxycodone ER instead of methadone, what do you do next when they're getting close to discharge if they decline Suboxone? Great question, Alex.
Yeah, and so that's that transition from phase one to phase two, and I have a very pragmatic conversation with the patient. Like, actually, in the beginning, I had this conversation. I'm gonna do it again because they probably don't remember it, or they were sick in the beginning, and it's hard for them to concentrate on it. But saying like, OxyContin isn't forever, and we need to switch you to something, and it's got to be that. Unfortunately, your two options are terrible. Both of them are bad. But this is what we have for you. We've got buprenorphine and methadone. And when you leave the hospital, if you don't want to go back to using fentanyl, then these are your options. And we'll try to, meet any way possible to get you on it. We'll do whatever you need to do to get there. And then I spell out how we typically will do those transitions and work with that person. And really, what we're trying to do is figure out logistically, like what medication is going to work better for you anyway. Do you need the structure of methadone? I hear that from a lot of patients, like, yeah, buprenorphine doesn't work for me because it gives me a choice. And then I hear the exact opposite with the very next patient. Like, I can't do methadone. I can't go there every day. And, then buprenorphine is the medication for you. Or like, hey, I'm a roofer and I work every day. I can't go to a methadone clinic. I got a full-time job. Well, then methadone isn't the answer for you. It's got to be buprenorphine. But then for the people who choose, like, hey, both of those options don't work for me, you got to figure out what's the next best step. And I warn them, like, hey, detox is going to increase your risk of overdose death. I don't think that's a good option. You got to go to something, or maybe inpatient rehab, so you can come down slowly off of these opioids and then get a dose of Vivitrol, because Vivitrol in the hospital is just not an answer for people because they have tons of opioid dependence still.
Thanks. And then Kit asked, health system challenges getting docs to follow guidelines. How are you guys disseminating these guidelines for ED and inpatient care? And do you have supporting order sets?
I try to stay away from doing order sets. I know, Kit, you're a big advocate of the order sets, and I know the research involved there, and I think it's really great. But what my big concern with order sets was, while it's going to bring the bottom up, I think it also is going to bring the top down. And if the people aren't thinking about it and they're going to blindly click an order set, it's just not going to be sufficient. So, like, I can't have a doc just ordering 60 TID of OxyContin for every patient. They need to have real conversations with patients. But it's something that I'm constantly conflicted by. Like, boy, I probably improve a lot of care by just creating an order set. And I think that's where we're working towards, is creating some order set. Um, yeah, but we're going to create an order set for micro-induction for sure, because that's going to be complicated for some people.
That's great. And then Samantha Zweibel said, what are your recommendations for working with providers who believe the best way to treat pain in OUD is to minimize opioids, not overflow the bucket as a basic principle, which I think is, despite the knowledge that the patient has high tolerance.
Yeah, that's a tough conversation, and I think there's a lot of bad ways to go about it. But I think probably my best approach is, and maybe just tells about the person I am. And I'm trying to explain to them, like, this is what's in heroin. Do you realize what's in heroin? And this is what they do every day. And trying to sort of, I think having them understand what's in a dose of heroin opens a lot of people's eyes. They're so surprised when they hear, oh boy, there's 300 micrograms of fentanyl in every bag. Oh, okay, now I understand why my 5 milligrams of oxycodone doesn't work. Um, and changing the culture, I think it's is a really beneficial thing. When you have a handful of docs on board, and if it's a hospitalist you're trying to convince to do this, when there's other hospitalists now doing it, I say I'm not the only crazy person here. Look, your colleagues are doing this now too, and they're on board with it. And so having that credible messenger and someone in their own field, or maybe like you work on one trauma surgeon to indoctrinate them and let them disseminate it through their field. I think that's really real sort of the best way that I've seen. And lots of education. Boy, I have hit every department in my hospital. I've given lectures, the same kind of lecture to every department. And I keep constantly going back to them over and over again. And in academic settings, talking to the residents. We opened up some spots for a rotation to have, medicine residents rotate on addiction medicine service. And so now they're bringing it back to their service. And they go, oh, yeah, actually, when I was on the addiction medicine service with Dr. Durazio, this is what he said. And now they're disseminating information without me even being there. And it's great. And now, oh, I've had this experience and this is what we do. And this is how he would manage it. And now, other services are starting medications.
Yeah, I mean, I agree with that. I guess I have two comments. The time for limiting opioids is in opioid naive people, and that's really where we've had such an opportunity over the past 10 years to change everything. But these are people who already have dependence and tolerance, and now you're talking about harm reduction and really optimizing their, treatment plans in the hospital. Nobody's benefiting from a 25% AMA and readmission rate, and progression of disease. So, but I agree that, our health system is a challenging place to take these on. But
Yeah,
that's
it's
why
the
we have
difference there
big
between like
committees.
prevention
Yeah,
and tertiary care.
Yeah,
prevention, yeah, everybody wants to keep opioid naive people naive, right? But when the cat's out of the bag, when they already have a use disorder, withholding opioids is not going to solve the problem.
right. Exactly. It takes a, it takes a lot of clinical maturity to realize that, and so it's just, why we need to continue to educate. Um, well,
And then using
so,
using analogous scenarios like diabetes, I like to always do
mhm,
that. Like,
mhm.
just telling people to stop eating sugary foods isn't going to fix their diabetes. Yeah.
And I like the slide about, you know, you've had 3 heart attacks, so,
Yeah.
well, it's good. All right. Well, thank you so much, Joe, and thanks everyone for your participation and interest. I know, we're eager to continue to work on the culture in all of our health systems in Philadelphia and all across our country. And I do think that we've had some exemplary opportunities in the care that you're providing at Temple and Cooper, and really just, vanguard leaders in the field. So thanks everyone, and I hope we can continue this and learn from each other. And I'll take recommendations for future expertise that we can have in this forum. It's the little silver lining of COVID. So thanks everyone. Have a great day. Oh, and I should say this.